Good morning, my dear students. Welcome back to another class. Today we'll be discussing about ganglionic blockers. In my last class, I hope you remember my last class, it was on anticholinergic drugs. In anticholinergic drugs, we discussed drugs that inhibited the muscarinic receptors. Today, under ganglionic blockers, we'll be studying those drugs which will inhibit the nicotine receptors, or the drugs that inhibit or block the nicotine receptors are called as ganglionic blockers or neuromuscular blockers. Here we will be discussing about the ganglionic blockers. Okay, by definition, a ganglionic blocker is a type of medication that will inhibit the transmission between both the preganglionic as well as the postganglionic neurons in the autonomic nervous system, and they may often be called as nicotine receptor antagonist. Ganglionic blockers are otherwise known as nicotinic receptor blockers. Now, the one thing you should remember is that they inhibit both the synaptic as well as sympathetic as well as parasympathetic ganglia, and the effect will be depending upon the dominant tone on the tissues, which is which system, that is sympathetic or parasympathetic. Depending upon the tone, dominant tone, the response will be present. Okay, this picture shows a diagram of a parasympathetic ganglion with a preganglionic nerve as well as a postganglionic nerve. Here, just a description about the receptors. There are three receptors: M1, M2, M3. What do you say? A brush up of what we studied previously. Now, let me tell you. I told you the action will depend upon the dominant tone of the system. That is, if suppose in blood vessels, that is, ganglionic blockers will block sympathetic as well as parasympathetic ganglia. So, and the effect will be depending upon the dominant tone. An example for that is in blood vessels, the dominant tone is a parasympathetic system. So, what will happen if you stimulate the parasympathetic system? There is vasoconstriction and rise in BP. But when you give a ganglionic blocker, since this sympathetic system is dominant, the blood vessels go into vasodilatation and there is a fall in BP. This is how the dominant tone come into the picture. I hope you understood with that fact over here. Ganglionic blockers are not used usually in clinical practice, but you should know what are the actions of these drugs. Coming to the classification of ganglionic blockers, they are divided into competitive blockers or quaternary ammonium compounds and persistent depolarizing agents. In under quaternary ammonium compounds, the names are hexamethonium and mecamylamine. Just remember these two names, hexamethonium and mecamylamine. Under monosulfonium compounds, trimethophan is the drug. Okay, and the second group that come under blocking agents are persistent depolarizing blockers, that is nicotine and other anticholinesterase under larger doses. Nicotine also larger doses. Here we need to study only very few drugs as they are not used clinically or never used very usually in clinical practice. Just know the names of these drugs. In your exams also it will be asked, just try two drugs, ganglionic blockers, which act as ganglionic blockers. Just the names of two drugs. No need to go in depth of these drugs. Okay. So here we should remember these four names. First one, tetraethylamine. Tetraethylamine ammonium. Okay, tetraethylammonium, hexamethonium, decamethonium, mecalamine, and trimethophan. Here remember hexamethonium, decamethonium, mecamylamine, and trimethophan. First drug, TEA or tetraethylammonium. That was the first drug which was recognized, which has a very short duration of action. Now, hexamethonium was the first effective drug which was used in the treatment of hypertension. I told you, if it is a sympathetic tone dominant area, if you give ganglionic blockers, you will have vasodilatation resulting in a decreased BP. Now, coming to decamethonium, see it an analog of hexamethonium, which can act as a depolarizing neuromuscular agent, blocking agent. Coming to mecamylamine, is a secondary amine which was developed to improve the absorption from the gastrointestinal tract, while the quaternary compounds never was very less absorbed through oral absorption. Now, coming to trimethophan, it is a very short-acting ganglionic blocker, very inactive orally. It is usually given intravenous infusions. So, four drugs that act as ganglionic blockers you should remember are hexamethonium, decamethonium, mecamylamine, and trimethophan. Okay, the effects of blocking agents. As I told you earlier, they block both the parasympathetic and the sympathetic nervous system, and the effect will be depending upon the dominant tone in the organ system. Now, this table will show which organ, the respective organ, with which is a dominant tone. Suppose it is in the heart, it is a parasympathetic system that is which is having the dominant tone. There will be tachycardia. The effect will be tachycardia. In blood vessels, as I told you with an example earlier, it is sympathetic system which overpowers, so vasodilatation, and there is decrease in BP leading to hypotension, etc. Now coming to eyes, there it is the parasympathetic. The result of inhibiting the parasympathetic system will lead to mydriasis or dilated pupil. Ciliary muscles, also ciliary muscles, intestine, bladder, and midsection functions, all there. All these systems or organs, the parasympathetic system dominates, and their respective uh, actions takes place. Only the change it is you see is in the sweat glands. In sweat glands, it is a sympathetic system which overrules, that is a cholinergic system, and there finally if you inhibit that, there is inhibition of sweating or anhidrosis. Okay. Indications for ganglionic blockers, where all we can use ganglionic blockers, but it is not used usually, but still the indications are malignant hypertension, neurosurgery to control hypotension, orthopedic surgery to control hypotension, and autonomic hyperreflexia. These are the few indications. If they are used, they can be used for these four indications. Coming to the side effects of ganglionic blockers, it includes cardiovascular, includes orthostatic hypotensions with or without reflex tachycardia. ENT, the glands includes xerostomia, dry. Everything goes into dry. I told you glands are overruled by the sympathetic system. If you inhibit, the secretions will be lost. So xerostomia, dry eyes, blurred vision with a reduced bronchial secretion, and hypohidrosis. In GIT, there is decreased movement, gastric movement, so gastroparesis, constipation, and urinary retention. Under sexual dysfunction, there will be failure of erection and ejaculation. In overdose, there is a risk of peripheral circulatory collapse and paralytic ileus. Okay, with this we end up with the topic ganglionic blockers. Nothing much to go in depth to study about ganglionic blockers. In the exam, only one question will be asked from this part, that is what are the ganglionic blockers, or two examples for ganglionic blockers. Just remember at least two names, mecamylamine, or I have asked you to read at least mecamylamine or trimethophan or hexamethone. Any of the names just remember so that you can answer this question. Okay. With this we end up with ganglionic blockers. Coming to our next topic, that is smoking cessation. Another small topic. Coming to the next topic, that is smoking cessation. Just a few drugs on how smoking can be stopped with the help of drugs. One main thing you need is motivation or determination that you will stop smoking. Without that, these drugs are not going to function also. Okay. So going into a topic, what are the drugs? Or pharmacotherapy of smoking cessation. Before going into the slides, I'll just show you few pictures, two pictures, what bad habits smoking can do on us, and another picture where what are the ingredients that can cause harmful effects. Okay. This is a picture of this cigarette. Okay, and what it emits and what does it contain. Our main compound, that is nicotine, present in the cigarette, is one which is that causes addiction in us, and quitting makes it challenging. Since this agent, nicotine, is an addictive agent, coming out of smoking makes it difficult. Okay. You just go through the picture, read them, what and where they are used, and so you will understand what all harmful effects they can do on our body. Okay, coming to the mesolimbic dopamine pathway, which is very important in smoking. What happens when we smoke over? What happens when a person smokes? The nicotine in the cigarette will activate or will come and bind to the nicotine acetylcholine receptors in the brain, activate or release the dopamines in the brain. Now, this dopamine increases the positive reinforcement, that is the need for more and more, and also it activates the pleasure activity in the brain, that is it gives a pleasurable effect to the brain, that this substance is something which brings pleasure to your mind, so you will feel the need for more and more, nicotine, so you will have more and more smoke, so you go for more and more smoking. This is what actually happened. This is a vicious circle. Okay, so nicotine activates the nicotine and acetylcholine receptors in the brain, and then they activate the dopamine activates the pleasurable area in the brain. This causes the need of more and more cigarettes to bring the pleasurable activity. What is the exact mechanism of action? Nicotine comes and binds to the nicotine acetylcholine receptor, especially the alpha 4 beta 2 nicotine receptor present in the ventral tegmental area. Now, this is what which causes a release of dopamine, and this dopamine activates the pleasurable region. As I told you, nicotine will stimulate the dopamine release and will cause the pleasurable feelings, which will need the brain will ask for more and more pleasurable needs. So you will go on for repeated administration, and finally a tolerance develop in us or in the persons who smoke. Directly going into the intervention, or what can be done to prevent smoking or how to quit smoking. Now the PHS, that is a public health service, has emphasized on 5 A's. First one, ask. Second, advise. Third, assess. Then assist and arrange. In ask, what we should do is ask for how much of tobacco they use in a day, and when do they use them, and when they require them more. Understand the situations which they require the smoking, where they smoke a lot. Advise them to quit. We tell them to quit, we counsel them to quit, we show them, we explain them what are the side effects of smoking. Then we assess. Once they show the willingness, we assess the willingness to quit attempt. We check whether they are ready to quit or not. Then we assist them, that is we either we admit them in a hospital, check on them regularly, ask them for more details. Are they having the craving feel to have more and more cigarettes, and we arrange a follow up. After this all are achieved, we ask them to go home and come up for a follow up, and check whether all these are maintained or not. Before going into pharmacotherapy, the willingness to quit in the patient is a must to stop smoking. So, both medicines and as well as the willingness of the patient is required for quitting smoking. Coming to the pharmacotherapy, as I told you, nicotine is a psychoactive drug in the tobacco product which produces physical addiction. Now, researchers also showed that this can be as addictive as heroin, cocaine, and alcohol. Quitting smoking is very difficult and may require multiple attempts. Because of the withdrawal effects or withdrawal symptoms, patients will need more. They come into relapse. That is, they come and use these products. To prevent the withdrawal symptoms. That is, once you stop smoking, we go into withdrawal symptoms like irritability, anxiety, and difficulty, and the patient feels that if you smoke, all this will reduce, and they start going back into their older situation itself. So to prevent all this, we have dealt the nicotine dependence, treating nicotine dependence by two methods. One is nicotine replacement therapy and non-nicotine prescription. In smoking, we should understand nicotine is the one which pulls us to have more and more smoking. So first you should do, the nicotine dependence should be broken, or the connection of nicotine dependence should be, that circuit should be broken. For that, the two treatment therapies are nicotine replacement therapy and non-nicotine prescription medications. In under nicotine replacement therapy, there are over-counter prescriptions and prescriptions. That is, over-counter is that you can usually go to the pharmacy and ask for nicotine patch, gums, and lozenges. These nicotine patches are those which we can see advertisement in televisions, that is Ciplas nicotine gums. We usually nowadays we see these pictures, these advertisements. So you can go and ask. Once patient feels that he wants to smoke, in place of the smoke, you can ask them to have a nicotine patch. Then with prescription, you can have a nicotine inhaler and a nasal spray. This is how it functions. Is, suppose we need the patient feels to smoke, the nicotine is the one which makes them feel to have no smoke. So in place of smoke, we replace them with the NRTs. Okay. and the function of NRTs will be dealt, how the mechanism of action will be dealt in the next pages or next slides. Okay, then coming to non-nicotine prescription medication, that is two drugs which helps in smoking cessation, includes bupropion, which is an antidepressant drug, and varenicline. Okay, both will be dealt in detail in the next slides. Okay, coming to nicotine replacement therapy. Now, nicotine can act as a both stimulant and depressant. Okay, research also has shown that nicotine replacement therapy can reduce the number of cigarettes smoked and cut down the amount of dangerous inhaled smoke, which can cause harmful polycyclic aromatic hydrocarbons responsible for most of the harmful health effects. Usually, smokers are prone to have CA, that is lung cancer. Patients should also be counseled to stop smoking completely prior to the initiating NRT to avoid the potential risk of nicotine overdose. Suppose a patient goes on smoking and has we advise the patient, you have these chewing gums in place of smoking, but what he does will be smoking. He'll be smoking as well as using the nicotine tongue. In such cases he can go into nicotine overdose. And also, using two forms of nicotine replacement therapy, that is patch plus resins, can result in higher quit rates. Use of NRT is also recommended for a minimum of 6 to 8 weeks, not less than that. Okay, it should be at least 6 to 8 weeks to get an effect. Quit rates are usually range between 20% to for 24% with NRT. If you see with NRT, few side effects are present depending upon the site of administration. You will have mouth sores, skin rashes, or nasal and throat irritations. Coming to the mechanism of action of NRT, how NRTs functions. Suppose we have advised a patient to quit smoking, but when he has the feel of to smoke, we advise him as nicotine replacement therapy, such as a chewing gum. In the chewing gum, the amount of nicotine is very less. Now this will go stimulate the nicotine acetyl receptor, will release dopamine, but that release of dopamine will not activate the pleasurable area of the brain. So therefore the need for more and more smoke will be reduced, that is reduced craving for cigarettes and other tobacco products. So finally the need for more and more cigarettes will be lost, and he'll go into quitting of smoking. Okay, so NRT products still contains nicotine, which is harmful and addictive, but they deliver very small amount than cigarettes without any other harmful substance in tobacco, such as tar and carbon monoxide. Because in some people will keep on telling, even you are trying to stop nicotine side effects but using it as a drug, but when compared to the smoke, nicotine present in the cigarette is very small without carbon monoxide and tar. So here the benefit outrages the side effects, so it is used in as a therapy. Coming to the drug bupropion, as I told you, it is an antidepressant medication which is help to relieve the symptoms of nicotine withdrawal in quitters. Also, it reduces the desire to smoke and has a similar success rate to NRT. Sustained release bupropions are available with a dose starting from 150 mg daily for 3 days, increasing to 150 mg twice a day on day 4. Now, treatment with bupropion is started with 1 to 2 weeks before the anticipated quick date. When we counsel the patient for 2 weeks, during that time this can be given. The standard treatment course of bupropion is about 8 weeks, and it will yield a percentage of 30%, quit rates of 30%. And it should not be given in patients with seizure disorders, substance abuse, and other conditions that may lower the seizure thresholds. Coming to the mechanism of action, how bupropion helps. Now, this is a relative weak inhibitor of neuronal uptake of norepinephrine and dopamine. Interruption of the area of the brain that is associated with the addiction and pleasurable effect of nicotine, that is the relay of pleasurable activity, is cut by bupropion, and this helps in reduction of desire to smoke and dampens the physical symptoms of nicotine withdrawal. This is an alternative to NRT. When compared to NRT, this does not have nicotine in them, can be used very safely, and it should be seen that it is not used by people with epilepsy, liver problems, and with other eating disorders. Coming to another drug, that is varenicline. Varenicline should started 1 week prior to the identified quick rate, and titrating the dose from 0.5 milligram daily for 3 days, then into 0.5 milligram twice a day for 1 week, and then 1 milligram twice a day from the 8th day. Now the quit rates are about 44%, and it is very useful nowadays for stopping smoking. Mechanism of action. As I told you earlier, varniclin, no, nicotine, nicotine go and bind to nicotine. What is it? Nicotinic acetylcholine receptor, specifically alpha 4 beta 2. Now, this varniclin will go and bind to these receptors, and these agonistic activity will stimulate moderate levels of dopamine, just moderate levels of dopamine in the terminus synapse, and has an antagonistic property which competitively inhibit the nicotine at the alpha 4 beta 2 receptors. Even though it is a partial agonistic activity, it has antagonistic activity over the receptors, and no pleasurable effects of nicotine is being present. Now, this will also help to alleviate the symptoms of nicotine craving and withdrawal through its agonistic activity, while inhibiting the effects of repeated nicotine exposure by its antagonistic activity. The common side effects includes nausea, insomnia, and abnormal dreams. Others includes headache, difficulty sleeping, abnormal dreams, increased appetite. Now, varniclin can double the chance of successful quitting. Okay, this when compared to the rest two, this has a higher end in helping in quitting. Now, coming to few tips to quit smoking. Now, if you go on explaining to a patient like this, he will get agitated. But these are few tips which we can do to prevent a patient from stop smoke. Not prevent him, to help him in from quitting smoking. First is to hide the matches, lighters, and ashtrays from his side. Designate home as a non-smoking area. Ask people not to smoke around the people who has been advised to quit smoking. Drink fewer caffeinated beverages which may stimulate the urge to smoke, and avoid alcohol which may increase the urge to smoke. Also, change the habits connected with smoking. There are a few other points which can be, which I have mentioned. You can go read them and try counsel the patient with the respective points, tips. But before that, clear cut mind the patient also should have, that he will quit smoking, then only all these points will work out. If you are forcing a patient to smoke, it is not very useful. So with here I end up my class. Okay, stop smoking when we'll stay healthy. I hope you understood with my class today, ganglionic blockers and pharmacotherapy of smoking cessation. Both only one word questions will be asked from these topics. Thank you. Please do write your names under the to mark the attendance.